to let you know that the irony is not lost on me, the fact that my name is Philip Morris and I run a pulmonary rehabilitation company. So that always gets a few chuckles when I speak across the country. So what we're going to do today is we're almost finished and you can relax. This is not really a lecture. It's more of a presentation of best practice, okay? We're going to talk about what we do. We'll tell you who we are in a little bit, but talk about our experiences at UAB over the last year or so. But more or less, just kind of talk about this complex ventilator patient, the challenges that they pose. Everybody in this room knows this, so a lot of this is going to be kind of redundant. You'll already know about it, but let's talk about it anyway. So we're talking about the complex ventilator patient with multiple comorbidities, sits around in ICUs for a long period of time. How many folks have taken care of this kind of patient? Yeah, high up so I can see, okay. So you know that this type of patient is typically notorious for long lengths of stay, high readmissions, and increased hospital-acquired conditions. Hospitals across the country really do have challenges every day with this type of patient, and they all have them. They reside in all the different ICUs, okay? Our patients, there'll be a slide here in a moment which we'll talk about of where our patients come from, but the MICU, you've got your frequent, I call it your frequent travelers, your chronic respiratory failure patients who've exacerbated. You've got your SICU, your post-surgical patients have got multiple comorbidities which have resulted in respiratory failure secondary to their surgery. You've got NICU, of course, with your TBIs, your traumatic brain injuries. You have your strokes, etc. And then, of course, with UAB, we've got a significant number of trauma patients because obviously they're a major level 1 trauma center for the region, not just the city. We haven't had that much in South Florida. So, fatigue factor, MD and RN. Everybody can kind of get what I mean when I say fatigue factor. You've got these patients that have been for sometimes weeks and occasionally months in the ICU. So when I talk about fatigue factor, I'm talking about the nurses taking care of that patient who they just can't get weaned. And there's a fatigue factor. It's like, there's nothing more we're going to be able to do with this patient. The patient sort of gets tagged as, okay, inability to wean. We're kind of tired of this patient. We're kind of tired of everything we're doing. We're exhausted on this patient. MDs are no different. They get a fatigue factor when it comes to these patients, and many times what happens in these cases is that the patient just gets transferred to LTAC, and they go off. Now, I do want to make sure, do we have anybody here that works for an LTAC? Okay, well, it's going to be really nice. I don't want to make sure I bash LTACs or anything. Long-term acute care hospitals are very necessary for certain types of patients, okay? But historically, and what I have seen across the country as I've spoken to hospital after hospital is that they're sort of notorious for increased readmissions. These patients come back to them, they don't get weaned, they keep them long periods of time, they don't get weaned, they get readmitted back to the hospital. So if you've got a patient that's in the ICU that's a difficult wean, they're sitting around for all this time, but the fatigue factor sets in, transfer to LTAC, you're not really helping that patient. So discharge to LTAC, you're disrupting their care because you're moving them, you're going to have to bring them in depending on where the LTAC is, the long-term acute care hospital is. They're going to be put into an ambulance and transported to that, or sometimes an air ambulance because it has to be a long way away. Depends on where the LTAC is related to the acute care hospital. So you have a disruption of care, and then the potential lack of incentive to wean. To be an LTAC, you have to have a patient for 25 days, minimum. So what's the incentive to get that patient in there and get them weaned, right? You've already sat the patient in the ICU for weeks, sometimes longer. Now you're going to send them to an LTAC to wean? Well, they can't. They're going to keep them there for 25 days. So where's the incentive? Where's the financial incentive for them to get that weaning process done quick? So that's an issue. Lack of effective early mobility in the ICU. How many folks work in the ICUs as a therapist? ICUs provide a high-touch clinical environment for these patients when it comes to nursing, there's no doubt. But if you folks have talked to a respiratory therapist, a physical therapist, an occupational therapist in the ICU settings or in the acute care settings, they'll tell you they got a lot of patients to take care of. That's just the way hospitals have to run. Any hospital executives in the room? Be careful, I don't want to offend anybody. Hospitals aren't very entrepreneurial in their thinking, so they have to staff accordingly across the house. So the therapists that work for me, I mean, they'll tell you, if they go in that ICU and there's a lot of things going on with that patient in the ICU and they've got a ton of patients to take care of that day, that patient may not get OT that day. That patient may not get PT that day, right? So hospitals struggle with early mobility in the ICU setting. Hospitals here in Birmingham are no different. So lack of effective early mobility in the ICU, and that, as you know, as respiratory therapists, is critical in getting these patients weaned. Potential for delayed sedation weaning in the ICU. Any nurses in the room? Okay. If you've been a nurse like I have for 35 years or so, and you spend a lot of times in the ICU, you know, whether you want to admit it or not, you're on night shift and you got that, those orders to wean off the propofol or wean off the medication that they're on. I don't know if you use propofol or they've got some other Precedex they use down in the hospitals in Florida. There's the weaning right there, but you sure would like to have a nice night, you know, so you may wean a little bit as the night goes on, but you know, where's that incentive? Again, not saying that the nurses aren't good nurses, I'm just saying that's the kind of things we deal with in ICUs. Sometimes patients don't get weaned as fast as we'd like to see them get weaned, because let's face it, a 12-hour shift with a difficult patient, weaning off propofol, weaning off Precedex, not that great of a night. So that happens, that's just the way it is, it happens. ICU psychosis, everybody knows what that is and how that affects patients' rehabilitation in the ICU. So the earlier we can get these patients out of the ICU, the better the patient's going to be. And then multiple ICU vent patients, lack of consistent weaning protocols. Basically what that means in a large hospital like UAB and other hospitals, nothing against the hospitals, you've got multiple ICUs, right? You've got multiple physicians in those ICUs. Trauma surgeons, kind of notorious, they like to do their own thing, right? The trauma surgeons kind of manage their own vents, if you've had experience with that. You've got your physicians in MICU, your physicians in neuro ICU. Everybody's kind of doing their things on vent weaning, so you've got a lot of cooks in the kitchen when it comes to weaning this patient. So lack of a consistent physical place for those patients to be with a consistent weaning protocol, with consistent acute care respiratory therapists weaning these patients, you know, it doesn't help the patient. They're just kind of all over. So what is that? What do we do? We're going to talk about some case studies. I love talking about case studies. These are actual things that have happened to some of our patients, and believe me, I could sit up here and talk to you for hours about wins that we have. Every week we have a call and we talk about the wins that we've had the previous week. But I just picked a few. I won't bore you too much. This one, and I know all of them specifically, this was a 62-year-old male, acute respiratory failure. He was in a level 1 trauma center in South Florida. You see his diagnoses there. Whoop, I can do this. Of course, trach, vented, and pegged. This was actually, you guys don't care much about the payer, but it was a managed Medicaid. 138 days in the ICU, 4 failed weaning attempts. Got a call from the medical director of the payer, which was a Medicaid provider, and they're like, listen, what can you guys do for this patient? And we said, well, send us the records, let's take a look at it and see. Because we had a unit in a sister hospital. So I took a look at the medical records and shared it with the lead respiratory therapist, and we both looked at it, scratched our heads, and like, why can't they wean this patient? We can't figure it out. So he said, yeah, send them to us and we'll do it. No sniff or LTAC would accept the patient, obviously, because it was on a vent. So day 139, the patient was transferred to SCU vent settings. You can see SIMV, rate of 6, 50% FiO2, PEEP of 5. So the guy had a lot of mental issues. He had a lot of tremendous amount of anxiety that maybe had not been approached like it should have been at the other hospital. So 10 days after we admitted him, so I spoke with him when he got there, spoke with the attending physician and the pulmonologist, and I'll never forget it because I was actually traveling, and I got a phone call I want to say it was about 10 days, a little after 10 days after he was there, from my respiratory therapist on the unit, he was like, Mr. Morris, I got somebody wants to talk to you. I'm going to hand him the phone. Well, initially I was just ticked off because I hate somebody to do that, right? They call you and then they just hand it off. Now, I got a family member that's getting ready to jump down my throat with both feet. And I was just, it was my birthday. And I was sitting there going, I can't believe he just did that. And all of a sudden the phone on the other end of the phone, thank you. Who the heck is this? It was the patient. We had weaned the patient. We had capped the patient 5 days after, and actually we capped him, and then he was discharged 5 days after that. We actually ended up weaning, capping, and decannulating and sent him home. So he got his life back after a level 1 trauma center couldn't do it. So this is one actually here, UAB. You probably remember this one, Chris. By the way, I want to introduce Chris Chapman as our lead respiratory therapist at our unit here at the University of Alabama, Birmingham. He's here so that when y'all start asking really specific respiratory questions, I can point to him and say answer. 65-year-old male admitted to level 1 trauma center. This was a swimmer. He was a very active gentleman. He was a swimmer. He had an arrest in the pool, I believe, right, Chris? He had a full arrest in the pool, was transferred from an outside hospital to UAB. You can see what his admitting diagnoses were. He went through 3 bronchoscopies performed in the ICU, failed extubation on the 3rd, trach performed on the 4th. He was transferred to us. You don't care who the payer is. After 8 days in the ICU, transferred to SCU vent settings, CIS control, rate of 6, 40% FiO2, PEEP of 6. 7 days after admission to the unit, he was weaned, trach was capped, 5 days. He was discharged to the IRU where he was decannulated. We didn't get credit for the decannulation on that one because they wanted to get him over to Spain pretty quick. As you can see, his length of stay was reduced, and I remember running into his wife in the hallway, Chris, and she was crying, and she was saying, thank God that UAB started this SCU, because without that, I don't think he'd be where he is today. So, all that being said, who are we? Who the heck am I? Why am I here? The company I work for actually contracts with acute care hospitals around the country. Been in business for 27 years down in South Florida, and what we do is we cater to the unique needs of the catastrophically ill, ventilator-dependent patient, those ones that we just talked about, the complex patients, and we help hospitals increase the throughput on these patients, reducing their length of stay, weaning them faster, and getting them through the system. So that's what we do, because as I said before, hospitals, as great and wonderful as they are not entrepreneurs. We're entrepreneurs. We want to do the very best thing for not just the patient, because everybody wants to do that, but for the hospital, for the system, for the payer, for everybody. We're going to talk about a win-win-win scenario here in a minute, and you'll see what I'm talking about. So what's so special about us? Well, we've been in business for 27 years. We've treated over 10,000 patients. Our wean rates, I'm not sure if anybody here knows what the national wean average is or what the national average is for wean rates, but it's less than 60%. And even the best of the best LTACs will tout 70%. And Modern Healthcare came out last year with an article of a hospital in New York City, or New York State, that had come up with this great idea about consolidating vent patients and treating them with a multidisciplinary approach. And I read it, kind of had to grin a little bit, because they were so excited that they were weaning at 67%. So we wean at 80%, we decannulate actually about at 64%. Our healthcare staff, it's a multidisciplinary, aggressive model, higher touch model, which we'll talk about in a minute as far as the clinician to patient ratio, and aggressive PT, OT, speech, early mobility. Remember we talked about the early mobility and the importance of that earlier. Weekly multidisciplinary rounds, very, very important, and very active family involvement. Anybody here know what a CMI is? Case Mix Index. Anybody heard of that? Case Mix Index is basically a number that the hospital comes up with, or the people that are a lot smarter than I am, that can determine what the acuity, the overall acuity is of the patients in various units in the hospital. So our CMI is typically between 13 and 14. That is almost twice of what the burn trauma unit is at UAB, to give you an example of how sick these patients are. So, how do we get these excellent outcomes? High-touch patient care. It's very important to keep everybody knows that in a step-down unit, you're going to have maybe a 3-to-1, ICUs 2-to-1 where it's necessary. So we have a patient-nurse ratio of 3 or 4 to 1. Typically it's about, I look at it on average across the board, and I can tell you it's about 3.3, 3.4 is what it ends up being. But that's not just about, it's not just about nurses. We are a multidisciplinary unit, so we're a relatively small unit with a lot of hands on deck. So if you're a nurse working on this unit, you've got side by side with your PCAs that are very, very good. Our PCAs are amazing. I just love our PCAs. Respiratory therapy is typically 6 to 1. Every unit's got about 2 respiratory therapists on the unit, and we've got an 11-bed unit. So what I hear from my respiratory therapist time and time again is that instead of having 20 or 25 patients and feeling kind of like a technician and just going from patient to patient and tweaking the vent or whatever, they're actually able to work on that patient and see the fruition of their work. And see how those patients are being weaned and be really active and responsible. And nothing gives you a better feeling than having those patients come back to see you weeks after they've been out of the hospital, that when they got there, you know, they were completely unresponsive on a vent, and now they're coming back driving their car. And we have that. So, respiratory therapists on each shift, PT, OT, and speech 6 days a week, or as often as they can get it. But we have our own physical therapist, occupational therapist, CODAs, LPTAs, as well as speech therapy. Of course, our speech therapist works very closely with the rest of the hospital. ACLS for all our RNs and RRTs, of course, and our multidisciplinary rounds. We work very closely with our families, but the weekly multidisciplinary rounds are really, really important. Those are run by our care manager, and it's a time where everybody, all disciplines are there. We do it in our particular unit here at UAB every Thursday. We encourage the family members to be there, and we have basically, it's just like any grand rounds. You go from patient to patient, everybody weighs in. You hear from nursing, you hear from respiratory, you hear from OT, PT, and speech. We discuss the plan of care and where we are. We encourage the family members to be there so they can address the team, ask questions, vent if they need to, because we're not going to do anything there that we can't discuss with that family member. So we're keeping their expectations, but also where they feel like the patient is in their plan of care. We're making sure that they're realistic, because as you probably know, sometimes you have the family's version and view of the plan of care, and then you have the actual plan of care. So these multidisciplinary rounds every week are very, very important for communication with the family. Something else we do that's interesting that you don't see every day is that we use Blue Beak technology. Every one of our caregivers, PCAs, respiratory therapists, everybody, nursing, wears a special badge among all the things. It's getting to the point where you can't hardly wear a badge because it's got about 20 different things on it, but one of the ones that we have is a Blue Beak or Bluetooth technology. They wear a badge, and in every patient's room and at the nursing station, there's a transponder. So we can measure exactly the amount of time per discipline that we're spending with our patients. We're very excited about that because we're going to be able to work with UAB to actually take this research, take this data, and do some white papers on this and related to outcomes. We already know we have outcomes, but now we can say, hey, this is how many hours were spent with PT, OT, or speech, or nursing, whatever the discipline is, and this is what the outcome was. I've seen research papers all over from a nursing perspective, outcomes related to nursing education, to shifts, whether it's an 8-hour shift or a 12-hour shift, all types of things, but time spent at the bedside or time spent with the patient by discipline, it's not anything out there. And this is just an example. You can see here the username, which is the respiratory therapist, the time that they were in the room, the time that they left, the duration or whatever for that particular episode. So that's just one of the things that we're doing. It's not to check up or be big brother for our staff. It's actually just to see how much time we are spending with the patients. It's also a good protection too if you ever have a problem. I mean, this is not why we did it. It's not. But you have a family member, for instance, comes up and says, you know what, Susie hasn't been in that room all night long. She has not been with my father all night long. Well, Ms. Smith, yeah, we can look right here and see that Susie was in there at 3:04 to 3:0 whatever. I mean, so we can document things like that. So it's really important, and I'm kind of hoping that hospitals will take note of this. So where do the patients come from? As I already told you, this is just by diagnostic category, but they come from SI, they come from MI, they come from NI. At UAB, they come from burns and trauma, and of course MICU for the frequent travelers, frequent flyers. Outcomes. Now, I'm very proud of this. Most of our patients go to IRU, Spain, inpatient rehabilitation unit. Spain rehabilitation is the one at UAB. Of course, Health South, Lakeshore, they own that. So most of our patients go there. That's 20.8%. Very small percent go to hospice, but we are sometimes a hospice bridge. In other words, a hospital might come to us and say, hey, we're going to send you this patient because the family simply can't accept that their family member is end stage lung cancer, and they're just not going to get any better. So we're going to send them to you because we told the family that if you can't fix them, they can't be fixed. So we do end up being what I call a hospice bridge in some cases, and it's unfortunate. But we've actually, and I don't mean to laugh about this because it's not funny, but we have had some hospice patients or some patients that have come to us with the understanding they would probably be going to hospice, and then we wean them. So, you know, that sometimes that's a little bit difficult because then they're very hard to place because they still have an end-stage disease. What I'm very proud of here, though, is that 25% of our patients go home. Now, I know Chris can attest to this, and if you've seen some of these patients, but we have had some of the sickest patients since our experience at UAB that I've ever seen in our experiences in South Florida. And I tell you, I've seen some of them come in there, I wouldn't have given you a dime that they would ever make it out. And we've had several of them come back to us. And it's just so rewarding to have those patients come to you. I've got another case study I'll share with you in a minute, but I mean, we had, I don't have this one, but I still want to share it because I think I'm going to have time. But there was a double lung transplant patient at UAB who'd been there for 3 years. Had not been home in 3 years post-transplant, had 2 transfers out to LTAC, who bounced back, never could get off the ventilator. The hospital had pretty much, and the family, had pretty much come to the conclusion that this patient would live out her last days at UAB Hospital. We were given, and I'm not going to give you the full thing because it was complicated, but we were given this patient with the directive of just get her to BiPAP at night, right, Chris? Just get her to BiPAP at night, get her off the vent, just get her to BiPAP at night. That's the best we can hope for. That was the highest bar they could come up with, and then send her back to transplant. We'll decide what we'll do. Am I right? We did have one little blip where she had a reaction to some medication, and she had to go to the ICU, but then we got her back. Long story short is this woman was weaned off the ventilator completely. Did we decannulate her, Chris? Yeah. We decannulated this woman. She went to Spain for a short period and then went home to Mobile. And I got chill bumps still talking about it. This was last year and I still got chill bumps talking about it. This is a woman who never thought she'd see her home again. She thought UAB was going to be her last place on this earth. And she was able to get home, and that was probably the best story I can tell of any of the patients that we've had. We've had a good number, but that one was very special, and she was a very special little lady. So we talk about the everybody wins scenario, and I'm just going to go through these quickly because honestly some of these are sort of marketing, and I'm not trying to market to you. But the patient does win because better continuity of care. Continuity of care, as we said before, you're not disrupting the care, you're not putting them in an ambulance and sending them down the street or across town or to the next city to an LTAC. So we're keeping them in the hospital and keeping that seamless care for the patient. Physicians can continue to follow their patients into the ICU, into the SCU. Consulting physicians continue to see the patients. So again, just less disruptive. Unnecessary transportation, as we said, aggressive rehab, early mobility, shorter length of stay. Our average length of stay is about 24 days, so that's really not bad considering these patients have been there for a long time. Lower hospital-acquired infections and conditions. We're very proud of our history there. More personalized attention because of that lower patient-to-clinician ratio. And then, of course, we have our own individualized case management. Family wins because they're not stressed out as much. They're going to be able to stay in the same place that they're comfortable with. Okay, they're in the same hospital that they're comfortable with. They're very involved in the plan of care, as I mentioned in our weekly multidisciplinary rounds, which include all these: nursing, respiratory therapy. All these folks are there. liberal visitation policy. We have a lot of family members that spend the night in the unit. And then, of course, as I said, the lower ratio. Doctors win because they continue to follow their patient. There, again, there's no disruption in the care. They see the patients. They come into our unit and see the patient. They don't have to get in their car and go down, assuming they would, and go to another LTAC and look at their patients. They're not transferring their patient to another physician to be cared for. Consulting physicians are able to follow their patients because all of the ancillary staff in the hospital come into our unit. So ID, cardiology, you name it, they're coming into our unit, taking care of the patients. It's not us and them. It's not. It's very seamless. We're just another unit of the hospital. Access to successful therapy win protocols. We have our own protocols, but we work very closely with our host hospital to develop these. Weekly multidisciplinary rounds, and of course the hospital intensivists love us because we're cleaning out the ICUs. We're getting the ICUs moving. We take the patients just as soon as they are hemodynamically stable. The earlier in the ICU process that we can get a patient into our unit, the better outcomes we have. So we're not an ICU, so we're not going to be titrating vasopressor drips and things of that nature, but as soon as we get that patient to a point where they're hemodynamically stable, they're still sick, believe me, very sick, but once we get them, we can start our multidisciplinary aggressive rehabilitation. So it keeps us from taking up a bed in what I call the high rent district, which is the ICU, and gets them into our unit, and then we can move them along the continuum a lot better. Nobody cares about the payer. The hospital wins because they do have better outcomes, better utilization of their capacity, of course, core measure compliance, lower HAIs, lower HAPIs and falls, et cetera, et cetera, et cetera. So let's talk about the UAB experience. We opened in UAB in October of 2016, and after our first year of operation, a full 12 months, of course we're well into the second year now, we decreased their vent days by 2.7 days as a result of opening this unit. Our first year wean rate was 81%. Remember what I said the national average is less than 60%. There's an LTAC in town that in their brochures, they market 70%. Our wean rates are 81%. Decannulation rate the first year was 65%, which is pretty remarkable. I mean, 65% of the people are getting their trach out completely and going home. We're not going home necessarily, well, they get home eventually. So that pie chart that I showed you earlier, it showed 25% of our patients go home, but then it showed you another percentage that go to IRU. Well, keep in mind, those patients going to IRU, Spain, or rehab, well, they're also going home. So I don't know how many of our patients are actually ending up at home after IRU and SNF. Some of them stay in the SNF, the skilled nursing facility, because that's just the best place they're going to be and they have no home to go to. But those who have good homes to go to that complete their rehabilitation in the inpatient rehabilitation unit, they go home as well. So I wish we would come up with that number because frankly I don't have it. Average length of stay 24.9. That's a reduction of 20% for this particular patient category for UAB. Mortality rate, thankfully with UAB, they've got all these people, again, a lot smarter than me, that can look at all of these things. And they took the type of patient, and we can drill down and get to the type of patient by diagnostic code, right? These patients who are got multiple diagnoses, they're on a vent, they're trached, and they're pegged. You take that group of patient, we know exactly how many there are and where they were the year before we opened, and look at their mortality rate, and then look at the mortality rate after we opened for a full year, and there was a drop of 21% mortality rate. We would love to have a shorter length of stay. We love our length of stay, to be honest with you, to be about 21 days, but at UAB it's closer to 25 total. But the good thing is that we're dropping the mortality rate. These people are living. We're actually moving along. We're saving their lives, letting them get their lives back, so I can live with that. Readmissions of less than 6%, which is an 80% reductions for DRGs 3 and 4. Medicare DRG 3 and 4 are trached and vented patients for 96 hours or more. DRG 4 is the same thing, but with complications like ECMO. As I said before at the very beginning of the presentation, these patients are notorious for readmissions, right? They get transferred out because of the fatigue factor, remember, and whatever else. They get transferred out to a SNF too early. They get transferred to the LTAC, and then the hospital gets dinged with the readmission. And believe me, hospitals don't want readmissions, especially if they're Medicare patients, because they get dinged financially big time for readmissions from Medicare, CMS. And even payers like Blue Cross Blue Shield can hurt you. Everybody read about what happened to UAB some years ago with decreasing their status when they have issues like readmissions and bad customer service and things like that. So hospitals have an accountability to the payers. And when we can reduce by 80% the readmissions for these patients, I can assure you it really helps them. Which brings me to the last note, which is that it's not just a cost center for the hospital. The hospital made this decision in 2016 to bring us in there and to take care of these patients. And a couple of comments by some higher ranking physicians were saying, I don't care if it even costs us money, let's do this. Because it's important and what they do is important. But that's not the case. We typically will go in and save on a 12-bed unit. The savings to the hospital is typically $1.6 to $2 million, or $1.5 to $2 million. At UAB it's $1.6 million, and it would be more, but at UAB we're not taking care of any other patients in the region. We're only taking care of patients at UAB. So we don't take patients from other outlying hospitals and directly into our unit. And in some of our units in Florida, we have taken patients from other hospitals. So not only are we saving the hospitals money, but we're actually making money because we're bringing them good paying patients in from outside hospitals. So that's just the business end of it. That's not the clinical end of it. So case study 3, this is a very interesting case study. Young girl, 18 years old, from New York. She was a student at University of Alabama. She'd gone to the beach on a trip with a bunch of the kids. She got back and she was found down in her dormitory, incontinent with a fever of 104. She was evaluated for presumed autoimmune demyelinating disease. She was admitted with encephalopathy, respiratory failure, and UTI, 18 years old. Beautiful young girl. Initial admission, of course, was, or likely admitting diagnosis, viral encephalitis. She received a trach, feeding tube, failed multiple weaning attempts. She was transferred to our unit. Now, she was not so much, and I have to admit this, she was not so much a respiratory win for us, although respiratory had a huge part of it, because once you wean a patient, guess what? You got to keep them off the ventilator too. So I think Chris's group did an amazing job in, getting her rehabilitated from a pulmonary standpoint, and also getting her decannulated. So they did a great job. But this was also a huge win for our rehabilitation staff, because this little girl had a lot of cognitive issues as well, as you can imagine, with viral encephalitis. So she came in to us. The family was from upstate New York, not a really well-to-do family, and they really needed to get her back home, but it was going to cost over $20,000 in an air ambulance to get her back up to New York. So they said, well, let's send her to SCU and see what we can do there. So they sent her to us on 421 on the ventilator. She was on assist control, 40% FiO2. She was on the ventilator when she came to us. She was, okay, my bad. She was not on assist control, so scratch that. I made a mistake. She was on 40% trach collar when she came to us with cognitive deficits. During her stay, she received, of course, all the multidisciplinary care. She was decannulated on 427. Feeding tube was discontinued. She was able to actually book her flight back home on her own laptop. And you can see that's her holding her booking in the chair. And then, of course, the top one was actually when she came back to see us. She's the beautiful blonde in the middle with the Alabama t-shirt, doing extremely well. So this was another of many wins that we've had in the special care unit at UAB. So here again, I just wanted to present you with what we are doing at UAB, what we do across other hospitals, and what I consider to be a best practice in the care of the complex ventilator patient, which is basically consolidating patients across the hospital into one multidisciplinary aggressive ventilator weaning unit with specialized training for the nurses, the respiratory therapy staff, the PT, the OT, and the speech. We talk about teamwork, you know, I was in an interview this morning, as a matter of fact, the reason I couldn't be here earlier is we're hiring another occupational therapist. And he asked what we expected of him. And I said, you know, everybody, it's almost a cliche. You talk about teamwork, right? You got to be a team player. But with us, teamwork is not a cliche. It is a very, very important thing to do, because our nurses don't just have to get along and work as a team with their other nurses. Our respiratory therapists don't have to just work as a team with their other respiratory therapists. They work across disciplinary lines. I have gone into our unit and seen our speech therapists and respiratory therapists working with a nurse to change a patient. It's amazing to see that kind of work between disciplinary lines and to see, but you know what, when you have the outcomes that we have, then it makes it all worthwhile. And then if anybody has any questions about what we do, or you're ever interested and you want to come by and visit and tour our unit, all you have to do is let us know, and we'll be happy to arrange for a tour and see what we do and see the outcomes that we're having.